firstly, to Jürgen, we're going to talk a little bit broadly about setting the scene in ICU. Can you tell us what are the main changes that you've seen over the last 10 years?
Oh, wow. It's a good question. And since I like to talk about history and such, actually, I may take you even back a little bit further, actually, because ICU, don't be worried, it's not too far. Because ICU is actually one of the youngest specialties in medicine and only really came to life in the 50s, interestingly, with the pandemic. Those days was polio. And that was where many patients suddenly needed breathing support machines, and the iron lung was then developed. And that was where ICU came to life. And indeed, our ICU came to life just very shortly after in the 60s when it became, I believe, I wasn't alive then, but I believe became one of the first ICUs in Australia to operate as a separate unit. And that was, of course, quite relevant as this hospital then evolved into becoming a quite specialized hospital, including the first heart transplant in '84, which means that, of course, these patients need to be looked after in a specialized unit once they had the surgery to ensure that success of those procedures. And that is certainly one of the mainstays of ICU. I believe it's now 22 years. Nikki was around when we moved into our new space, and that was certainly at the time I came to Australia, and I was told you have to go to St. Vincent's. That's the state-of-the-art ICU when it was built, and that was I think where we were proudly been developing on. In the following years, I think the next milestone for me, it was 2008 when I came to the unit, but 2009 was probably more important because that was when yet the next pandemic hit and our swine flu patients basically came in suddenly. And
Sorry, Jürgen, who came in then? The spinal patient?
Swine flu. It was the H1N1 pandemic we had.
Swine flu.
Right. Many of you may remember that actually when we had suddenly a lot of patients coming in with breathing problems again. And that was also when intensive care itself organized itself as becoming its own specialty and became a college. And we in St. Vincent's started to become involved in ECMO, which is a retrieval service which takes the very sickest patient with breathing and cardiac problems, heart problems, to St. Vincent's on that special machine, which keeps you alive effectively, to give them further special treatments in our unit. And that is subsequently, or has since been actually one of our main, one would say, burdens or challenges as well, actually, because it takes a lot, of course, you can imagine, to go and pick up these patients from all abroad. I think moving on to those last 10 years, I think that is certainly something where ICU becomes more and more specialized. We use a lot of equipment to look after these most vulnerable patients. But of course, I think most importantly, we always have to keep in mind that it is about people, it's our patient, but it's also about the very specialized trained nurses and doctors and allied health practitioners who actually work in ICU and makes that place actually something worthwhile and functioning. So where ICU in St. Vincent stands is basically, I think, I like to look at intensive care in general as a crossroad between many specialties. And indeed, for us, it's in particular those, of course, with heart and lung disease, as we are the referral center for heart and lung transplant. But maybe less known, we are also the state referral place for bone marrow transplants. We do kidney transplants. We have artificial hearts. But we do have a lot of other sick patients coming to us via our front doors through emergency. And we look after all of these. And for that, we're very grateful to have very sophisticated equipment, thanks to many people here in the room. And we try to use this equipment to give treatment on the bedside in a qubit, which is 20-25 square meters, really. You've got lots of machines, and we can talk more about that maybe later, but to keep patients alive, but to measure and monitor and manage their life function and to support them as well. One example is, for example, diagnostics. So if we need a diagnostic test, we can go and have it done, say, in an MRI scanner or CT. Moving around ICU patients isn't that easy. They're obviously very unwell. So we do have other machines we can take to the bedside, like echocardiography, for example, and that's again something which was sponsored through Coron Foundation grants, that we do have machines, and we do have also training programs for echocardiography where our doctors actually learn to use those devices in the middle of the night at the bedside whenever they're needed, rather than having to wait for a particular scan or particular assessment or particular technicians to come in. So this is something which ICU is all about, is basically bringing the treatment and the monitoring to the patient in the ICU. And I think that's one of the most important characteristics an ICU has. And indeed, sometimes I look at all the equipment, you can almost look like a little airplane cockpit or a computer on wheels. If you look at the beds on themselves only, actually, they are quite sophisticated these days. So I'd rather turn to the nurses usually and then ask them to move them, because it takes special training really to do that. So this is, in a nutshell, I guess, actually how intensive care has evolved over 10 years or longer to be a very specialized area and a specialty indeed, which looks after very sick patients and has got very well trained and very specialized people to do so.
Jürgen, thank you for that. And you did mention the role of philanthropy and how that has helped in ICU. Could you just extrapolate a little bit on that, about the way that the support that people in this room and online are giving to ICU? How does that, what are the specifics of how that works?
Yeah, sure. So what we certainly had a lot of help with over the last years, and I think particularly in the mid-2010s, 2016, I was around then actually, we had a live ball where a lot of funds were raised to basically provide us with the very essential life support machines and around the bedside. I'm talking here specifically on ventilators and cardiac monitoring. And these are really as part of the machinery we use every day. Ventilators, for example, many of you may think of this in some movies. You can see like that little bag in a cylinder or so moving. They're much more complicated and sophisticated nowadays, actually, and allow patients to even wake up while they're on a breathing machine, and physios can work with them. And on the other end of the spectrum, they can provide very sophisticated modes of ventilation, which allow even very sick lungs to receive enough oxygen. And on the other end of the spectrum are those monitors I'd mentioned. Really, we integrate things which previously been maybe developed in other areas of the hospital, like in cath lab, where the angiography suite, where cardiologists measure your heart function and pressure with catheters. We now have catheters which can actually be introduced to the patients and connected to those monitors, and we can, for example, measure minute by minute cardiac output, meaning the blood pumped through the heart, which is a very important number if we monitor and manage our patients. And then we use pumps to support this actually, and give medications to support heart functions as well. So all of that is by no means simple, and it is, we're really grateful and also well-timed that we'd received these state-of-the-art monitors and ventilators, I believe around 2018 and 2019, because very short after we needed all of them and more, because COVID hit, of course, and we suddenly received a lot of patients coming from all over the state, being very sick and being very dependent on those devices. And that was certainly one of the biggest challenges I went through, and many of us went through when we had over the last 10 years as well. And indeed, story didn't end it there, actually, and I think we mentioned that already. We, over the last few years, are now upgrading our ICU capacity by basically building 6 state-of-the-art new ICU beds, which are really single rooms, which with special negative pressure facilities, and really going to change the way we practice ICU in our unit. So we,
Fantastic.
again,
I
very
really want to
grateful
hear
for that.
more about the negative air vetting, how that works. But I will go to Aidan, and then we'll come back to that if when we've got time. Thank you. Aidan, you're in the private ICU. Could you tell us, how do the public and private work? I didn't really understand the extent of how big or how important that the ICU in the private hospital is.
Yeah, that's right. So I was going to answer a question about how we work together and the benefits that are coming to the patients from that. But when we were discussing earlier that maybe a lot of people understand how the 2 ICUs work, and Nikki might be able to help me a bit more with the public. But what feeds the public ICU is from the emergency admissions from the emergency department, car accidents, all that sort of stuff, needing really specialised care to go into the ICU there, or whether it be from their theatres, which are doing massive cases and really, really fascinating stuff, lots of lung and heart transplants, like Hergen was talking about, and really, really massive surgeries, and they need lots and lots of care following that. And ICU in the public are capable of giving that really, really specific care and do an amazing job. Also, any patients that are on the wards in the public hospital who then go on to deteriorate may need to be admitted into the ICU as well. And on top of that, even still, Hergen was discussing earlier about the ECMO, which is a retrieval service, which, from all over the state, is that right? They might need to fly out and collect somebody and bring them back for the ECMO. So there's a lot of channels into the public ICU. On the flip side, in the private, again, we do lots and lots of surgical cases, and they're big cases. They're really complex. Lots of cardiac surgery, lots of cancer surgeries. And head and neck, tracheostomies, all sorts of really amazing stuff. And those patients in particular need a lot of support. And the private ICU is more than capable of looking after those patients. And as well as the patients on the ward, again, like the public hospital, if they deteriorate and they need some extra care, then the ICU and the private can absolutely do that. And I think one of the things that really helps that is I'm not sure if there's a collective noun for intensivists. Is there maybe
Intensivist says so.
a haunt of intensivists? But the team of intensivists, 6 or 7 of them, 7, 8,
10.
I'm in the private, yeah.
10.
rotating
For the big.
rotate through both the public and the private hospital. So that's like amazing in the fact that the intensivists who are really specialised and have amazing skills are able to take the things that they learn and experienced in the public hospital and all the complexities of those things that come through there and transfer them also into the private hospital and give us capacity to really look after the sickest of patients as well in the private hospital.
Yeah, right. And coming back to that original question about the way you work together, it sounds in corporate Australia we'd call it collaboratively, but there is a collaborative sort of relationship, isn't there?
Absolutely, and I feel it's reasonably unique in that the 2 ICUs are maybe 20 metres apart. We're not that far apart, so we're co-located and we're able to utilise that to work together on a lot of different levels. for instance, the ICU nurses in the private hospital are facilitated to do postgraduate study with the public ICU in their course that they run, which is a fascinating and really great course, and something that I did one a long time ago. And so the benefits of that is that the private nurses can go and experience the public ICU, take a lot of experience from that and bring it back to the private hospital. As well as all sorts of other things that being co-located brings with that is there's specialists that are available to both, and a lot of them work in both the private and the public ICU hospitals. So patients have access to all those specialties.
Yeah, fantastic. Aidan, thank you. Nikki, on that point, why do nurses, ICU nurses, need specialist training?
Okay, so all nurses, they hopefully come into it with a passion for nursing and caring for the patients, and we will go through a registered nurse training, which is all very similar, and then people choose to specialise, or perhaps they've had an experience, or they're just attracted to a particular specialty area. So why does the nurses have to do more advanced? It's because of the higher patient acuity. So we're looking after the most complex and most critically ill patients due to their nature of their illness or their injury. And so when the registered nurse comes in, not only has to use the qualification that she's of her registered nurse training, but also needs to specialise further. We do take nursing staff these days as a new graduate. They're very unprepared when they first come in, and they need continual support. But all the nurses need to develop, because they are looking after normally one patient for one nurse. And what that means is they're looking after the whole holistic care of that patient. And it may be that, there's something wrong with the cardiac side of it, the heart surgery, a heart injury, or a brain injury, but you're actually looking after the total body, and you have to anticipate and learn to anticipate what might happen. You've got to think critically. You've got to know all your theory about all the physiology and what to do if this happens. So basically, they require the specialist's theoretical knowledge for this advanced practice. And also, during that training, they learn to basically think on their feet using initiative, critical thinking, and using those advanced nursing practices to also learn to operate this fantastic technology that we now have. It's wonderful, but with every new machine and every new technology, you have to be able to safely operate it. And you're at the bedside all day, and each nurse has to be accredited on each piece of equipment, which takes time and a lot of support and education. So probably when you first come into ICU, you may begin just to get used to the area. You may be buddied up with somebody. You may have some very basic knowledge, and you're sort of weaned onto your first patient with the help and support of another more experienced nurse. And from there, you get some experience, and you may go through a mini introductory course. And hopefully that most of our staff now will go on to do a postgraduate intensive care course, which is a tertiary qualification. And from there, they become more expert in their field. And then they, in turn, can help to buddy up and teach other staff that come in. I think the difficulty these days is, as you know, I've been in this particular intensive care for 32 years, but that's not how it is now. And we're finding that the new generations, they're very transient, They come into one area, they get itchy feet after about 4 or 5 years if you're lucky, and hopefully they stay in the specialty area, but they may go off and develop into nursing leaders, educators, clinical nurse consultants, specialists in other fields. They go overseas. They're very, very transient, and they may move between ICUs, but hopefully if they move, somebody moves to us. So we also have to look to find skilled up nurses. We can't just fill the intensive care with brand new nurses all the time. We have to be able to support those new ones coming in. So it's a bit of a revolving door. So although we have lots of nurses going on to bigger and better things because they're so highly trained, we also have to welcome the new nurses in and keep educating. So it's just perpetual learning environment.
I should actually, I do have not a conflict of interest, but my daughter was a nurse, not in ICU, but here at St Vincent's in the private, in theatres. And, you know, the whole issue of nurses' pay is something that's not related at all to tonight. But what are the qualities that you're looking for in a nurse, an ICU nurse?
In an ICU nurse, I think the first thing is obviously you would want what every registered nurse should be compassionate and empathetic, somebody who is very passionate about learning and is very prepared, and somebody that works well in a team. So they have some social skills, some good interpersonal skills as well. And they make a great fit for ICU. Going on from there, I think they also need to be quite organised, have good time management skills, very good communication skills. Some of these things you learn with experience because at the end of the day, you also need to be able to multitask. You have to be able to think on your feet. And also, I think there's another one that we struggle with sometimes, and that's resilience, because you never know what's coming through that door next. COVID, Bondi Junction incident, you have to be prepared for the worst case scenario, and but even just a simple death can be very challenging for some nurses. You do become more resilient, but hopefully you never lose that compassion and empathy.
Which is why a lot of people consider nursing in the first place, isn't it?
Absolutely, yeah.
And by the sounds of what you were saying earlier, Nikki, it sounds also like they need to have a bit of technical nous to be able to operate some of these machines.
Unfortunately you do now, and even though it's superseded by another machine or something better, or it does something extra, it's like, oh no, we've got to learn another one. And, and it's just, it's exhausting, and that's the way technology is in our personal lives as well, but very much so in ICU. We're now each bed is surrounded by lots of different equipment, nothing like 32 years ago when I first arrived.
Thanks, Nikki. Sam, you are the Director of the Private and Staff Specialists in the public.
Yep.
Could you tell us a little bit about trends? Like there's some global trends, but Australia's quite trendy, aren't we?
Absolutely,
Yeah.
absolutely. I mean, trends within the ICU, or what we're likely to encounter, or what we're likely to see. I think if we look at it in 4 sort of broad problems, I mean, one that everybody's touched on is technology.
Yep.
The next one is ICU design and the ICU environment. The next one is the patient populations that we're likely to encounter, and possibly emerging diseases and new disease processes that we might need to get our heads around, or maybe completely unexpected. So let's go back to the first one, which is technology. Okay, we've all talked about the technology, and everybody needs higher degrees to operate it, but this is in a state of continual evolution. The technology is going to become less invasive. It's going to produce us more real-time data. There's also going to be new biomarkers. And we need to be able to put all this information together and utilize this information in real time, to make real-time decisions to improve patients' outcomes, hopefully detect patients which are going to be deteriorating earlier. And with all this information, we've got to be able to process it. I think this is where we're going to see the use of AI, artificial intelligence within the ICU, of rapid data processing, rapid analysis, and being able to pick up a patient which may be deteriorating far better than we can with all the learned algorithms that AI is using. So that's quite an exciting area.
Sorry, Sam, did you say a patient that's deteriorating better?
Well, a patient which is deteriorating, we may be able to pick them up quicker with all the use of with AI.
Thank you.
There may be an increased use of automation within the intensive care unit. For example, at the moment, there's lots of drugs and infusions, and those infusions, every time we need to change the dose, the nurse has to go in there and tap the dose and alter the dose. By use of closed feedback loops, i.e. monitoring the patient, that will be able to self-titrate it and actually individually titrate that to individual patient care. So there'll be a progress to automation. This will also not only in drugs, but also will happen with ventilators, with inbuilt algorithms, which will be able to sense, how the patient's responding to the ventilator and adjust the amount of support that's actually happening. So it's quite an exciting time. How long that's going to come, I don't know. The next area is the intensive care design. When we talk about intensive care design, what we want to do is to have an environment which is better for patients and their families. So what's that going to happen? It's also we want better access, patient access to the intensive care unit. So what's that going to look like? Well, inevitably we're going to have larger intensive care units. We're going to have more beds to service more people. Okay. The other thing is the intensive care units are going to be architecturally designed. They're going to be less clinical in their appearance. They're going to be acoustically more friendly. Intensive care is a horribly noisy place. I don't know how many people have been through there, but there's a lot of alarms, a lot of signals going off. So they're going to be more patient-friendly. The beds are going to be more comfortable. They're going to be more interactive. There'll be use of things like circadian lighting, the same sort of thing that you see on aeroplanes, where they adjust the lights and the hues from blue to green, which will improve natural circadian rhythms, reduce the amount of sleep deprivation that's occurring to the patients. Okay. So the long-term effect of all these things, even when we take patients, not every room has got a window, for example. We may have virtual windows or virtual skylights in certain rooms. So the whole environment's going to be a lot nicer for patients to be in. Okay. So what's the end result of all of this? Well, it's going to reduce all the neurocognitive sequelae of long-term intensive care, such as anxiety, depression, PTSD, and hopefully enable patients to return to work earlier and have a better quality of life. This is what we're hoping to achieve with all the new intensive care designs. So there's a long way, to work on that area. I think the other advantage of that is by having a better working environment, we'll also retain staff. Nurses will be able to work, and medical staff more effectively. We'll be able to, also attract better and the brightest staff into the intensive care unit as well as a place to work. So it's quite an exciting field, the whole change in intensive care design. I think the other thing we're going to see, or there's a trend already, towards an aging population.
Yes.
There's already the patients that we're seeing in the intensive care unit compared to what we saw 10 years ago are older. They have more comorbidities. The good news is they're having lower mortality and better outcomes. So despite an aging population and older patients with more comorbidities, we're doing a better job when we're looking after all these patients. So there's going to be a change in the patients we're looking at. And as we increase in size, there'll be also this patient population more akin to the private with multiple comorbidities that need short-term intensive care that benefit from post-operative care with the intensive care unit, as well as those who are the sickest of the sick as well. So there's going to be a dual role with intensive care unit. The other probable thing is that we're going to be looking at this concept of intensive care without walls. So we're going to have outreach services supporting people on the ward, supporting other teams on the ward, and using our expertise and knowledge to support patients and teams within the hospital, not just within the walls of the intensive care unit.
Oh, wow.
Okay. I think there's going to be a number of disease challenges as well. And one area which this really does concern me is of antibiotic resistance. We all see this, we read about it on the news. We've already seen 2 pandemics. Jürgen's touched on the point of the H1N1 in 2009. We all remember quite vividly the COVID pandemic. I think it's likely that we're going to have, I think it's not improbable, I should probably say, that we may have another one, in the future. Therefore, we have to be adaptable, okay? We have to be fluid, we have to change how we work quite rapidly, okay? We've talked about these negative pressure rooms, which you're quite impressed about. I know you want to come back to that one.
I'm hoping you're going to get to that.
But I think eventually, rather than open spaces, every room within the intensive care unit will be a single room, so it can adapt and treat those patients with resistant organisms or new infections within an isolated area without having an impact within the intensive care unit. So I think this is some of the big areas that's going to happen, and changes evolving, maybe not in the next 5 years, but certainly in the next 10 years, 5 to 10 years on onwards.
Yeah, fantastic. And look, would you or Jürgen just quickly tell us about the rooms, about the need, because it's really cool. I'm sort of thinking scuba divers. You know how you have to decompress and you go into a room. And they lower the pressure or they up the pressure.
They're not that low pressure. So in essence, they're a sealed room with a very high-end HVAC system, heating, ventilation, air conditioning system, with a sealed unit with a negative pressure, with air coming in, so you're running the air through high-end HEPA filters.
Yes.
So you're removing any particles. And by creating a negative pressure, you're eliminating any contaminants, bugs, viruses, etc., leaving the room.
Right.
Each room also has an anteroom. So you enter that room via an anteroom. So it's essentially an airlock. So it reduces the chance of infection and cross-contamination.
Okay, but it's not about reducing the human connection, because I imagine that that's still critically important.
Absolutely, yeah.
And in pastoral care, which I'm studying at the moment, I love the way it's a sort of multidisciplinary. You were talking, Nikki, about how you're working together. And in pastoral care, so we're part of the hospital, but not part of the medical team. We're there to help people with their emotional and spiritual needs. And it's something that's been very important to the hospital for a long time. And I'm just amazed at how respectful the clinicians are about working with multidisciplinary teams to do that holistic treatment that you were talking about. On behalf of everybody here, we'd like to thank you, Jürgen and Aidan, Nikki and Sam.
Thank you.
And I think everybody's welcome to stay around for a little bit longer and introduce yourself and have some fun. And you've got a birthday party to get to, so you're out of here. Thank you, everybody. Good night.
Thank you.